Welcome to the presentation for Module 4 in Nursing 150, Care of the Patient with Urinary Disorders. First of all, to begin working on this module, it's important to review the concept of urinary elimination. Adequate urinary elimination is essential for body fluid homeostasis, which we all know is important. It means it's the ability of the body to maintain its internal environment. It's a happy state where everything is in balance, and urinary elimination is required to be functioning normally for homeostasis to be maintained. The concept of urinary elimination means the passage of urine through the urinary tract by means of the urinary sphincter and urethra. The kidney plays a part in that elimination by filtering the urine. It forms the urine by determining which substances in the body fluid will be eliminated and which will be maintained, and that again helps with homeostasis. Kidney function is critical in proper urinary elimination and for the body to be able to maintain homeostasis of all the body fluids. To begin to review proper urinary elimination, let's review a little bit of anatomy and physiology regarding this system. The renal system, like I said, includes the kidneys and the entire urinary tract. This is the ureters, the bladder, and the urethra. These are all integral parts of the urinary system, and they're required for the drainage route for the excretion of urine. And I'll go ahead and add the kidneys here. So the kidneys are the main organs. And these guys here are kind of the part of the tract that maintains elimination of urine outside the outside of the body. Remember, the ureters is what connects the kidneys and the bladder, and we'll see that in the next picture, and the urethra is actually what takes the urine out to the outside of the body from the bladder. So here's a picture of those organs that we just talked about: the ureter, the urethra, the urinary bladder, and then of course the kidneys here. Kidneys are very essential parts of maintaining health. They maintain body fluid volume and composition and filter waste products for elimination. They help regulate blood pressure. They help regulate your acid-base balance. They also play a part in producing erythropoietin, which helps us to make healthy red blood cells. They also play a part in the conversion of vitamin D to an active form. So a lot of things, a lot of jobs that go on in the kidneys, and it's important that we maintain health of our kidneys. And just to review the other parts of the urinary tract, the ureters, each kidney has a ureter that's like a hollow tube that connects the renal pelvis of the kidney with the urinary bladder. Ureters are about a 1/2 inch in diameter and about 12 to 18 inches in length. The ureter takes the urine from the renal pelvis of the kidney by means of contractions of the smooth muscle, that's in the layers of the ureter. There are stretch receptors in the kidney pelvis that regulate this movement. This means that like a large volume of urine in the kidney pelvis triggers the stretch receptors of the ureter to increase contractions, which is kind of like a peristalsis that takes the urine from the renal pelvis of the kidney to the bladder. The urinary bladder is a muscular sac. It's directly behind the pubic bone. The function of the bladder is to store urine, provide continence, and enable voiding. There are natural secretions in the lining of the bladder that resist bacteria. The urethra is the narrow tube that lined with mucous membranes. That purpose is to eliminate the urine from the bladder. The urethral meatus is the opening at the end point of the urethra. In men, it is 6 to 8 inches long. and has 3 sections in men. In women, the urethra is only 1 to 1.5 inches long. It exits the bladder through the pelvic floor. So that's a basic review of the anatomy and physiology of the urinary system. In the next few slides, we'll talk about assessment of the patient with urinary disorders. In order to assess a patient who could possibly have urinary dysfunction, it's important to do a full patient history. Patient's age, race, ethnicity can all play a part, as with any other disorders. Talking about their history, asking them questions as far as medications that they take, blood pressure problems. This can all be associated with the urinary tract, since the kidneys play a big part in controlling blood pressure and filtering medications out of the body. Kidneys play a large part in filtering a lot of toxins out of our body, so questions regarding any exposure to any kind of environmental or chemical toxins could be significant in the assessment of the urinary tract. Other questions to discuss: socioeconomic status can be an issue, perhaps with the urinary tract due to lack of insurance, poor body image, poor self-cleansing, poor self-care, poor wellness habits, things like that. The patient does not have insurance. They might not be medicating properly for a blood pressure problem or other problems. Nutritional status is another piece of the assessment, asking them questions about the type of diet they're on. Fluid intake is a big one. What are they drinking? Are they drinking highly caffeinated drinks all the time? That can put them at risk for having urinary tract problems. There are a lot of medications out there that are eliminated via the urinary tract, via the filtration of the kidneys. And so in high doses, in large amounts, it can cause some kidney damage. Drugs that are famous for that, long-term use of NSAIDs or acetaminophen, can cause reduced kidney function. Other drugs such as some vitamin supplements, and like I said, and most of this stuff is like in large amounts over a long period of time, that can cause some urinary tract problems. Antibiotics, there's a lot of antibiotics that can cause kidney injury. And we monitor those levels very closely in somebody who's at risk. Gentamicin is an antibiotic that can cause kidney toxicity, so we need to monitor the patient's kidney function. Anybody with diabetes, lupus, other genetic or medical history such as that can sure raise some flags for us regarding risk factors for urinary tract problems. There are some kidney diseases that are genetic as well, so you would talk about any kind of a history of any kind of disorder such as that. Then talking about things such as incontinence, urinating at night, which is nocturia, just talking to them about daily habits, burning sensation, trouble initiating, voiding, dribbling, different things like that. So those are some of the physical symptoms that you'll begin to ask questions about as well. You will also begin to ask them questions about what their urine looks like, foul odor, how much they're going, things like that. Other issues to talk about with your patient as far as physical assessment. What about weight gain? Are they holding on to fluid? Are they edematous? Especially lower extremities. Things like that can indicate perhaps that their kidneys aren't maintaining that fluid balance. They can also begin to get confused if they have a buildup of waste from poor kidney function. Other things as far as the physical assessment is kind of assessing the kidneys, ureter, and bladder, doing an abdominal assessment, so palpation, inspect the abdomen and flank regions, while the patient's laying down, looking for any kind of abnormalities, discolorations. Especially in the area of the costovertebral angle. The CVA is located between the lower portion of the 12th rib and the vertebral column. I believe I have a picture coming up of the costovertebral angle. That is thought to be where the kidney is palpated. It's usually, this palpation is usually done by a physician or advanced practice nurse, but by doing this, we can locate a mass or areas of tenderness in or around the kidney. So this is done specifically to assess the kidney. Typically how this works is if someone comes in complaining of symptoms of any kind of a urinary tract disorder, maybe they're having burning with urination, pain with urination, not being able to initiate voiding, they will probably do a urinalysis, which we'll talk about shortly, and then they'll start to ask the patient if they have any flank pain. The reason they do that is any kind of infection that's in the urinary tract, if it gets up into the kidney, it's of a much higher concern because we don't want any bacteria getting into our kidneys. And so they'll typically ask the patient questions about flank pain. They'll do a palpate, kind of check that flank area to determine if there's any tenderness there. If there is, they might suspect that that the kidneys are involved, and that is a much more, like I said, worrisome issue. So so it's important to ask those questions about if the patient is exhibiting any symptoms that the kidney's involved. These are just some specific changes in renal function, urinary tract function as a patient grows older. Just age itself can put a patient at more risk for disorders of the urinary tract. Usually it's a lot of dehydration, decreased muscle tone, decreased capacity of the bladder, weakened sphincters as far as the ureters and the urethra. Just over time, other disorders, they are usually on more medication as we get older. That puts us at higher risk. And just usually by the age of 65, the glomerular filtration rate, which is the rate at which the kidney is able to filter urine, is lower. It's half the rate of a young adult. It's typically around 65 milliliters per minute. So that's how much the fluid the kidney filters per minute. And this can increase the risk, of course, of fluid overload. This gets worse if the patient also has diabetes, hypertension, or heart failure, other comorbidities. So these are just some things that in the older adult we're much more concerned as well. Older adults are at high risk for dehydration because they have less total body water than younger adults. They also have decreased thirst sensation, and they may have difficulty with walking or other motor skills needed for obtaining fluids. They also may take diuretics, antihypertensives, or laxatives that increase fluid excretion. Specific lab tests that can be done in order to assess the function of the urinary tract. Urinalysis, of course, is our easiest one. It's pretty quick and easy, pretty cheap. It's typically like part of a physical exam, like if you go in for your wellness visit on an annual basis, they'll just take a urine sample to check it because it's a good indicator of our health and our homeostasis. It's also done specifically if somebody has a suspected kidney or urologic disorder. Ideally, urine specimen for urinalysis is collected at the first morning's voiding. It's because that's typically when the urine is more concentrated. They might get a little diluted throughout the day as we take in intake and things like that. So that's typically, it can be done other times of the day, but the best time is in the morning. Different ways to collect urine. Just make sure that it's collected and sent to the lab as soon as possible. It can start, some of the things in it can start to break down after time, and it needs to be refrigerated if it can't be sent to the lab right away. And refrigeration delays this breakdown. Urine collection should be done as clean as possibly, as sterile if possible. And that's kind of hard to do, but we do do like a clean catch method in order to make sure that the urine is not contaminated with bacteria that's from the body rather than the urine itself or the urinary tract itself. It's important to understand that it should be collected as cleanly as possible. And that's if we send it for a culture. A urine culture and sensitivity is done to actually determine if there is bacteria there and if exactly what the bacteria is. That's the culture part of it. The sensitivity part of it tells us what antibiotic is appropriate to treat that certain germ. So what is it sensitive to? What antibiotic can we use? And that a culture and sensitivity is done so that we can very specifically treat the patient with the proper antibiotics so that we kill the bacteria that's causing the problem, if indeed there is a bacteria. Urine cultures should be collected prior to giving a dose of antibiotic. It's more accurate if you do that. So you should get a morning catch of urine for a urinalysis. And then if they want to send it for a urine culture and sensitivity, make sure you collect that prior to giving a dose of antibiotics. It's more accurate that way. 24-hour urine collection is just essentially what it says. You're collecting all of the urine that the patient makes in a 24-hour period. This takes a lot of patient instruction. They need to know that they're going to start in the morning of the day that they're going to do it, and make sure that they just understand how to preserve it. They're going to refrigerate it during the day, and make sure it's usually better if you time it and date it so when they start it, and that way they can just know when it ends. Typically when you initiate a 24-hour urine, you have them discard actually the first urine, and then everything within the next 24 hours they will keep. So many things that we can tell about a patient. We can basically, see how much clearance they are, how much they're clearing things throughout the day, just how well their kidneys are working throughout the day. So many things can be we can look at in a urinalysis, if it's a 24-hour or just a basic urinalysis. It's the pH of it, and the color, if there's any protein in it, glucose, ketones, and you can kind of review that, exactly what each of those indicate in a patient. And really review the instructions that you as the nurse would give the patient so that that specimen is collected correctly. Creatinine and blood urea nitrogen or urea nitrogen are other lab tests that can help us to identify if there are kidney disorders or kidneys dysfunction. Creatinine is the product of the breakdown of protein in the body, and the kidneys are the only way that we get rid of creatinine. So it's a good indicator of how well our kidneys are filtering. So there's two different ways to look at this. If you look at the blood level of creatinine and it's high in the blood, and then the level of creatinine is low in the urine, that means that the body is not filtering that creatinine out. And so that is an indicator that there is kidney malfunction, that the kidneys are not filtering well. They don't have a good filtration rate. So we may look at it in two different ways. We'll look at what the level in the blood is, and we'll also look at what the level in the urine is. And usually that creatinine, the urine creatinine, is usually from a 24-hour collection. Urea and nitrogen is similar. However, it can be affected by other things rather than just kidney malfunction. Dehydration can also cause an abnormal blood urea nitrogen level. Typically, the way that we look at this, if the creatinine in the blood and the blood urea nitrogen are both elevated equally, as far as they're both elevated about the same amount, then it's usually a kidney problem. If the blood urea nitrogen is elevated, but the blood creatinine is not elevated, it could really just indicate a dehydration in your patient. We'll talk about that more in class to make sure everybody understands it, but it's something that is called the blood urea nitrogen creatinine ratio that they look at to determine if it's a kidney problem or a dehydration problem. This is just a slide that just kind of helps explain the creatinine and creatinine clearance. Basically, that typically a urine creatinine clearance would require a 24-hour urine, and you would need to know instructions to give your patient for that. And basically, we monitor over a 24-hour period how much creatinine is being filtered out of the kidneys. If it's not very much, then so if it's decreased, it can indicate a renal malfunction. Other tests that might be utilized in order to determine the capability of the kidneys in the urinary tract is osmolarity and specific gravity. Osmolarity is referring to the amount of solutes in a solution, so it's the concentration of particles in a solution. Specific gravity is used to measure the ability of the kidneys to concentrate urine. So we're looking at like whether there's a lot of particles in the urine or it's mostly just water. Normal specific gravity is 1.016. 1.016 specific gravity to 1.022 is the normal specific gravity. Again, it may depend on the lab, but it's typically around that. This is where we're looking at where we want it to be. And as you can see, that would mean that this is how concentrated we want the urine to be. If there's no osmolarity here, that means that it's not very concentrated urine. It means it's mostly all water, no solutes. And we want some solutes coming out because that's what we're filtering. We want some stuff coming out. And then here, if you have this much osmolarity and your specific gravity is 1.030, then you have very concentrated urine. So we want it about right here. This would be like the perfect place for our urine to be. And basically it can help us determine someone's hydration status. So think about what would make your patient look like this. This is going to make your patient's going to look like this if they have an increased specific gravity and an increased osmolarity. Then they're going to have poor fluid intake, probably. That's going to be somebody who's dehydrated. And then somebody up in this category is maybe somebody who's overhydrated for whatever reason, fluid overloaded, things like that. All right, let's look at a few other tests. This is a little bit more, not invasive basically, but a little bit more definitive diagnosis test that we would do if we suspect that there is something more anatomically wrong with a patient's urinary tract and kidneys. A KUB is essentially an X-ray of the urinary system. It stands for kidneys, ureter, and bladder. So it basically is called that because you can see on the X-ray the kidneys, the ureters, and the bladder. And it's a structural thing. It detects any kind of structural abnormality in any of those parts. No prep, really. Basically just an X-ray to make sure they're not pregnant. And, you know, it's really quick and easy and non-invasive. Bladder ultrasound, bladder scanning is done. It's a non-invasive. It measures the volume of urine in the bladder. It can be performed to evaluate urinary frequency, the inability to urinate, or any residual urine. So this can, if somebody, it feels like they're not completely emptying their bladder, then we would have them void, go to the bathroom, go void, and then we would scan their bladder to see what is left in their bladder post-void. Sometimes if we have a patient who does not have adequate urine output, and remember what normal output is, it's usually, like 30 milliliters an hour somebody should be putting out. And if they're not, then we can scan their bladder to see, okay, is it because they just aren't able to void? Is there something anatomically wrong that they can't void? Or is it just perhaps that there's no fluid in there? So it can kind of just help us determine where the problem is. Intravenous urography is an x-ray that is done after the injection of a radiopaque dye into the patient's vein. And essentially what that does is it illuminates the renal system, and it can be used in order to detect anatomical abnormalities, if there's any renal calculi in there, any kidney stones in there. And remember, anytime you use a dye, you have to make sure that you get informed consent and that you ask the patient for if they possibly have allergies to iodine, seafood, or dyes. Typically, they're NPO after midnight, depending on when the test is. Sometimes they administer laxatives, and the reason that is that way they can clean their bowel out. And so if with a cleaner, the bowels are more clean, then it's easier to see the urinary tract. Sometimes remember just what you need to tell your patient. If you're instilling a dye into their venous system, it can cause them to have a flesh warm feeling or a salty metallic taste to it. Typically afterwards, we will encourage fluid intake to flush the dye out, especially if you have a patient who is already possibly having kidney problems. So monitor to make sure that you are giving them enough fluids to flush out the dye, and then monitor them for any side effects of the dye, and monitor the urine output afterwards. This is a picture of a possible bladder scanner. It's a handheld. It's an easy test to do. It's really informative. A lot of times, some of the hospitals, PCAs can do it because they have been properly trained to do it, and they might be asked to do it. So it is something you could delegate to a properly trained individual. So a few questions that you can use for practice. The answers can be found in the comment section of the PowerPoint if you choose to do these. And I highly encourage it. It's always practice for taking tests. Okay, moving on, we're going to be talking more about the care of the patient with urinary tract disorders, beginning with infectious disorders. Talking again about the ureters, the bladder, and the urethra. This is just a picture of all of them together here. Ureters, bladder, urethra here. And this is typically where infectious disorders begin, is typically when things are introduced through the urethra into the bladder, and infection can occur there. These infectious disorders are typically named for their location that they occur in. For example, urethritis is an acute infection in the lower urinary tract. Can also be cystitis, which means an infection of the bladder. Prostatitis is an infection of the prostate gland in men. Now, pyelonephritis we'll talk about later on in this presentation, and that is referring to a bacteria that is occurring in the upper urinary tract, and that is a much more serious infection. So it's important that the site of the infection is identified and treated appropriately. If it's occurring in the bladder, if it's a cystitis, we want to treat that appropriately and get it treated well so that the infection does not continue to spread up through the urinary tract up to the kidneys, because that can mean a much more serious situation. Factors that contribute to the start of a urinary tract infection can be things like obstruction, and that is if somebody is just something in that pathway of the urethra, the bladder, the ureters is blocked for whatever reason. Sometimes it can be if somebody cannot completely empty their bladder, and it allows bacteria to grow. The flow of urine is meant to go forward and have a certain pH, and that is a innate protective mechanisms. Things should not go up backwards in the urinary tract. If that occurs, then that causes bacteria to go up in the urinary tract the wrong way. Of course, kidney stones can obstruct the flow of urine, and we'll talk about those in the last part of this presentation. Diabetes can also contribute to the presence of a urinary tract infection, and typically that's because if there's excess glucose in the urine, it can change the pH of the urine. The idea of the pH is that we innately have a little bit of an acidic pH to our urine. That's altered, that's a protective mechanism, that pH is. So because in a little bit more acidic environment, bacteria can't grow. So if the pH of our urine is altered by something, perhaps diabetes could be one of them. The presence of a lot of glucose can alter the normal pH of urine and allow bacteria to grow. Glucose is in itself a good medium for bacterial growth, so that can be a problem. Women, it can be a risk factor. They are just anatomically, they are more at risk for having bacteria from the perineal area introduced into the urethra. The other things is all these products that women use, any kind of fragrances, spermicides, things like that, can actually alter the innate protective mechanism that we have. It can alter the pH. So any perfumed soaps and things like that that women are using can actually be worse for them. So they need to stay away. You just use the good old soap and water. Typically, men become at risk for urinary tract infections. Typically, younger men, it's usually a sexually transmitted disease that causes it. In older men, it's usually a prostate problem. Age, of course, we already talked about all the things that happen when we age that makes us at risk. A lot of that's dehydration and things like that. For women, it's also not only anatomically is a problem, but the age as they get postmenopausal, they lose estrogen, and estrogen is actually kind of a hormonal protectant that we have. And the loss of estrogen during postmenopausal women can put them at risk for increased urinary tract infections. For younger women, it's typically can be related to a sexually transmitted disease or essentially just intercourse itself. It's important to teach women to wash before and after, and to urinate after. The urine voiding in itself can cleanse the area and protect them against any bacteria making its way up their urinary tract. Cystitis is one of the most common infectious disorders of the urinary tract. It's a infection and inflammation of the bladder. This can be caused most commonly by irritants such as feminine hygiene sprays, spermicidal jellies, catheter use. People with long-term catheters can get a cystitis. More serious causes of it could be endometriosis, Crohn's disease, lupus, TB, things like that. Those are a little bit more serious. One of the most common causes of a cystitis, infectious cystitis, is typically the introduction of bacteria from the bowel that gets introduced into the urethra, and that's simply a lot of times related to poor hygiene, related to improper hygiene, that can cause the introduction of E. coli into the urinary tract via the urethra. Urinary catheters are the most common cause of urinary tract infections that are acquired during a hospital visit or a long-term care visit. One thing to understand is within 48 hours of catheter insertion, bacterial colonization along the urethra and the catheter itself begins. So basically that's when bacteria can start to grow and be introduced. So that's why, I don't know if you've heard, in some of the hospital floors, especially the surgical floors, if a catheter is inserted due to a surgical procedure, the catheter has to be out before 48 hours. And that's where we came about that 48 hours, is because that's when bacteria colonization can actually occur. So we want it out before that happens so that we do not allow for that patient to get a urinary tract infection. And the reason this is a big deal is most of us can recover pretty well from a urinary tract infection. It typically does, though, cause another day in the hospital. The other thing is we just talked about it, older patients who get a urinary tract infection, it could actually cause very serious infection, especially if it's not identified early and treated appropriately. And that could lead to a very serious infection called Urosepsis. And we're going to talk about that in a few slides down the road here in this presentation. It's important to review. There's a table in your book that talks about the best practice for patient safety and quality care regarding minimizing catheter-related infection. Key points to make sure that those don't occur in the event that someone does have a catheter. It's things like making sure that they are draining appropriately, they're to gravity, using sterile technique when inserting the catheter, maintain a closed system, maintain unobstructed urine flow, monitor and report any signs and symptoms, making sure you use the secure device for the patient. Catheter care daily is important, and making sure just monitoring urine output as well, for sure. These are the common symptoms of bladder infection, urinary tract infection, burning with urination, urgency, frequency, those kinds of things. Basically, a discomfort. Urge to urinate frequently in small amounts is considered frequency. Urgency is a feeling that they need to go all the time. So it's pretty high incidence of this. It's about 8 million healthcare visits annually for a urinary tract infection. So health promotion and maintenance is an important thing for a healthcare provider to be able to do, is to teach people, if we can determine the cause, try to help them to prevent getting these infections, because they can, it's not that common, but they can turn into a very serious infection that can be life-threatening if not treated appropriately. There's a good table in your book in chapter 66 regarding preventing a urinary tract infection. And it talks about drinking enough fluids, getting enough sleep, avoidance of the use of fragrance products, and careful with products. Avoid using, wearing irritating underwear. Loose-fitting cotton underwear is best. Emptying your bladder before and after intercourse. Do not routinely delay urination. So, those nurses that go a whole 12 hours without urinating, that's a problem. Other things that are natural ways to prevent is cranberry substances, such as cranberry capsules or tablets or juices. That is regarding, it's not a treatment for it, but it's a preventive measurement, because the cranberry can minimize the glucose in the urine, and so it decreases that ability of the bacteria to grow. Apple cider vinegar ingestion, like a couple tablespoons a day, and juice is thought to alter the pH a little bit so that it does not create a good medium for bacteria to grow. So basically it prevents it from growing. Sometimes topical estrogen to replace the estrogen that postmenopausal women have lost, things like that. So make sure you review that table, because we need to know that as nurses, how to teach patients to prevent from getting urinary tract infections. Okay, diagnosis, treatment, nursing care for a patient with a bladder infection, also known as a urinary tract infection. We already talked about it's diagnosed usually with a urinalysis is one of the first things that we do. And that will indicate that there are the presence of bacteria, white blood cells, or blood in the urine. And that is usually indicative of a urinary tract infection. The presence of more than 100,000 colonies per milliliter, or presence of 3 or more white blood cells, indicates infection. Make sure you understand how to teach a patient to do a clean catch midstream specimen. It's wiping from the front to back. Begin the stream of urine, stop, and then start again and collect it after you start again. And sometimes that can be obtained getting a straight cath if needed, and that would be a sterile procedure. Just making sure you understand as a nurse, because that would be your job, is making sure that that gets collected and gets collected well enough so that we can definitively determine if somebody has an infection or not. Other diagnostic things that can be done is a cystoscopy, and I think that's listed later in the presentation as well. But basically, a cystoscopy is usually more diagnostic. If somebody's having recurrent UTIs, if we think there's something anatomically wrong, perhaps that's causing a backflow of urine, or the patient not being able to void, this basically is introduced into the urethra, and it's got a little camera on it, and they can kind of go in and look around and see what's going on in there anatomically wise to see what's causing someone to have frequent urinary tract infections. When a patient is positive on a urinalysis for a urinary tract infection, they will most likely send it for a culture and sensitivity, which means it's culturing for the exact germ growing so that we can see what antibiotic it's sensitive to, and that's how we treat it. A lot of times we know as providers that E. coli is the cause of 90% of urinary tract infections, so we'll go ahead and treat them with a medication that will kill E. coli. One of the most common drugs used and the most effective is a drug called nitrofurantoin. Some people might know it as macrobid. That's the brand name. Generic name is nitrofurantoin, and it usually reduces bacteria in the urinary tract. Treatment of choice usually for urinary tract infection, unless someone cannot take nitrofurantoin for some reason, but it's usually a pretty effective drug for that. And as with all antibiotics, you got to make sure you tell them to take the entire prescription of the antibiotic, regardless of if they feel better or not. They should drink plenty of fluids with it as well. It's the same as with other medications. If they don't take it all, they can, the antibiotics, they can lead to an infection reoccurrence and the bacterial drug resistance if not all of the regimen of antibiotics is taken. Another drug that can be utilized for bladder infection, especially because it's in the classification of a bladder analgesic, it can reduce bladder pain. It's called phenazipyridine. Pyridium is a brand name that I recognize for that. You might recognize it too. But it's phenazipyridine, and basically it's kind of like for bladder spasms, and it's over the counter now. You can buy it over the counter, so you can recommend that your patient get that for any kind of bladder discomfort. It's almost like an analgesic for your bladder, which is wonderful when you have a urinary tract infection. The one thing about this medication is it will turn your urine red or orange, and that could scare them, so you want to make sure you notify them that. And it can stain their clothing or toilets, so they're going to want to flush a couple of times when they use the restroom, because it can stain their toilet, so they'll need to go flush and then flush again to make sure that all washes down. They need to usually take it with or immediately after a meal to decrease any GI disturbance, but it's a good drug. Other nursing care, like I said again, make sure they get fluid intake, maintaining a fluid intake, and we're talking water, not caffeinated drinks. Caffeinated drinks just dehydrate you more. So a patient needs to have good fluid intake with healthy fluids, such as just plain old water is the best way to keep our urinary tract healthy. Sufficient is usually 1.5 liters of fluid daily. Again, cranberry juice could be a way of preventing urinary tract infections, and that cleaning from front to back, especially for women, is really important for them. That's a great way to prevent urinary tract infections. Okay, I mentioned urosepsis as a very serious infection earlier. It's a life-threatening situation. And this is happening at times in especially the elderly when a urinary tract infection is not identified and treated early, what this means is that the bacteria that has gotten into the urinary tract can actually spread to become a infection in the bloodstream. So if this infection gets so bad in the urinary tract infection, it can actually be spread into the bloodstream. When that happens, it's a very systemic effect all over, and it's just going to affect the patient's whole body, this infection, and it's called urosepsis. And a lot of times it is complicated urinary tract infections that occur in older adults, and this is why a lot of older adults are confused and perhaps sometimes incontinent, and the whole, identifying the dysuria and frequency is harder to identify because they're already incontinent. Sometimes the patient's so confused that they can't tell anyone that they're having discomfort. A lot of times it's displayed in other mannerisms, such as the patient becoming combative or more confused. I do know that a lot of older adults that come in maybe to an ER, to a doctor's office, with their caregiver saying that they're way more confused and way more combative lately, the provider will typically go ahead and get a urinalysis, because it could be as a result of a urinary tract infection that the confused older adult is unable to communicate to someone. And remember, they're already at risk when they're older because of dehydration, poor fluid intake, and just the ability of the kidneys to work well as we get older anyway. So lots of risk factors here. So the big thing is we have to do a lot of those preventive measures for these older adults that are at high risk for getting these. We also have to be on the lookout, if they do look like they might be getting a urinary tract infection. If their urine output decreases, if it looks really concentrated, if they have a catheter, we have to be very, very careful to take good care of that and not to introduce any bacteria. So, because if they get septic, they're going to end up in an intensive care unit. And what it leads to is multi-system organ failure and septic shock, which will lead to death. So it's just important to understand that if we do not identify a urinary tract infection and treat it well and treat it appropriately early, it could lead to a life-threatening situation such as urosepsis. Okay, another reason that urinary tract infections need to be identified and treated early and treated well is because the longer that bacteria is in the urinary tract, perhaps it starts in the bladder. The longer it's there and not treated, it can travel up the urinary tract up to the kidneys. And that is what we call an acute pyelonephritis. So it's an acute infection of the kidneys. Pyel, refers to the kidneys. And nephritis, the NEPH refers to the kidneys. So acute pyelonephritis is an infection of the kidneys, and typically that means when the bacteria has continued to the upper urinary tract. This is serious as well because anytime there's an infection in the kidneys, you risk the chance that there is damage to the glomerular filtration of the kidneys, and it could be permanent damage to it. So, and the patient typically presents as a much more sick patient as opposed to a bladder infection. When the bacteria gets into the kidneys and creates an infection, there's an acute tissue inflammation that occurs within there, which can cause tubular cell necrosis and possible abscess formation. Abscesses are pockets of infection, and they can occur in the kidney, and they can cause some serious tissue damage in there, scar tissue to develop, which is going to cause permanent damage to the ability of the kidney to work well. The most common cause of a pyelonephritis is an E. coli, as is the same as the bladder infection as well. So the signs and symptoms of a pyelonephritis is a little bit different than a bladder infection or a lower urinary tract infection. These patients are going to have significant fever, chills, tachycardia, and they will have flank pain. And they'll have that tender costovertebral angle that we talked about earlier. because that'll mean that their kidney is tender and sore. They'll have abdominal pain because since the abdominal wall and organs are close to the kidneys, it can cause some abdominal, like almost just belly pain, because just referred pain to the area that's close to us. They can even develop nausea and vomiting, and they'll have the burning and urgency with urination as well, but they'll have the other symptoms that makes them appear as a much more sick patient. And it's important to remember, like I said, when people come in with signs or with complaints that they are having burning with urination frequency, the provider will typically say, are you having fever and chills? Are you having flank pain? Let me check your kidney to see if it's tender. Because what they're looking for is to determine if it's gone up that far in the urinary tract. Because if it has, it's a much more serious situation. This is just a visual picture of the inflammatory process that occurs in a pyelonephritis leading to impaired kidney function here, and why this is such a severe, much more serious situation. It's very treatable. It's treated with antibiotics as well, but it's much more aggressive treatment because we got to get this treated before it can do too much damage to the kidney. And hopefully we've kind of answered all these questions within this discussion. Urinalysis. Urine CNS is going to be done for these patients as well. This patient might be one of those patients that requires a KUB, so we can look at the anatomy to determine if we can see any inflammation, abscess formation, or defects in the kidneys or urinary tracts that's causing the pyelonephritis. These patients will be treated with the appropriate antibiotic for the bacteria that is identified with the urine culture. Nutritional therapy is also going to be adequate calories to help them heal. Fluid intake is recommended to be at least 2 liters per day, sufficient enough to dilute the urine. This is a picture of that assessment of the costovertebral angle, just basically kind of in that area there under the 12th rib, kind of squeezing them there. You just give them a little squeeze, and if they act like you just shot them or they hop off the table like that really hurt, then you would suspect that they have a pyelonephritis, because that area should not be that tender. These are some more questions in the next few slides to test your learning, to practice answering questions regarding the content. I encourage you to try to answer them and look at the answers in the comment section. Okay, the next topic we're going to discuss is urinary calculi, which are stones that can form in the urinary tract. These stones can form and cause an obstruction within the urinary tract, which can cause an infection. These stones also can move if they develop within the pelvis of the kidney, the renal pelvis here, and then try to travel down these tiny little ureters. It can cause the patient quite a bit of pain, and then it can also get stuck in the ureters, obstruct the flow of urine, and cause some serious damage to the kidneys if not moved well. The exact reason why people develop stones is not completely understood. It's some crystals that are excreted in the urine, and sometimes they will form stones. It's usually fewer than 10% of people form stones, but a lot of them contain calcium is one part, and uric acid is another part of the stones that they've been able to test. Typically they find that most patients that develop stones are someone who has a slow urine flow. It's usually it's about fluid intake. And basically if they have a low fluid intake, it causes a slow urine flow and results in the ability of these stones to form. There's a small amount of the population that has a metabolic problem that causes them to absorb an excessive amount of calcium from their intestinal tract. It's really not about calcium intake. It's more about how they absorb the calcium that they do take in, and that really leads to a calcium buildup in the blood, and as that goes to the kidneys, the excess calcium is filtered and develops into stones. The fluid intake is poor. Someone is dehydrated, the ability to create stones is greater in the patient. So really the biggest cause of that they've been able to determine in all patients of renal stones is dehydration, poor fluid intake. The second top cause of the formation of these stones is usually some metabolic defect. And it tends to run in families. It tends to be a genetic link to it. Patients who have gout, which we'll talk about in Module 6, have a tendency to develop kidney stones as well. Diet is not considered a risk factor for stone formation. However, in those patients that have that hyper ability to absorb calcium from their diet, those patients would not want to add calcium to their diet. They would want a good balanced intake of it. Because if they're absorbing it higher than most people, the more they take in, the more they're going to absorb, and the more at risk they're going to put themselves. The formation of stones also tends to be more common in males. It tends to occur in young adults or during early middle adulthood. The formation of these stones may not cause any problems. However, if they get large enough, they can, and they're sitting in the renal pelvis, they can cause an obstruction of renal flow, and that can be a problem. Again, when they start to move, when they get into the ureters, they typically cause an unbearable pain, and this severe pain is commonly known as renal colic. It's a flank pain that can radiate to the abdomen. Anybody that's ever had one can tell you it's the worst pain they've ever had. It can cause nausea, vomiting, and just very severe flank and abdominal pain. They'll begin to have some difficulty urinating, some pain with urination, potentially some bleeding in their urine due to the trauma caused by the stone going through the urinary tract. So they're usually diagnosed by an x-ray. The KUB x-ray can sometimes see it. CT scan maybe. Ultrasound can maybe see some stones in the renal pelvis. Nursing care for a patient with a renal calculi is focused on pain management. Like I said, it's like the worst pain they've ever had. Typically, some anti-inflammatory medications along with sometimes opioids have to be used initially for the acute pain that it causes. Prevention of infection is important. We need to identify if there's a bacteria there present and treat it. Monitor for urinary obstruction. So that means, is there urine flow? Are they making urine? Are they going? Monitor their eyes and nose is very important. If there's an obstruction, this could be a life-threatening situation because if that urine backs up the urinary tract and just sits in the kidneys, that can cause kidney damage that can lead to kidney failure pretty quickly. Fluid intake is increased in order to help pass that stone if possible. And then the urine will be filtered. So basically when they do void, they will use a little filter to determine if we can capture that stone and send it to a lab for analysis to determine what it's made up of. So perhaps we can determine why the patient developed it. If it is a lot of calcium, it could be one of those patients that has the genetic tendency to have an increased absorption of calcium from their diet. Toradol NSAIDs is one of the NSAIDs that's used very commonly in patients. You just have to watch for any GI upset that might cause. Again, hydrating the patient is typically a good treatment. The other thing is lithotripsy, which is a shock wave. I believe I have a slide. The next slide might be about that, so we'll talk about that then. This is just a good visual to show the signs and symptoms that someone might have a renal calculi and all the diagnostic tools that we use to determine if that's indeed the case. But this is definitely what your patient will look like. They will be definitely in a lot of pain, and like I said, it's more common in males. All right, lithotripsy is a treatment that could possibly be for those patients who have a large amount of large stones in their kidney. These are shock waves that are used to break that up into small fragments so that the patient might possibly be able to pass them. They it's typically can leave. It's typically not terribly painful, pretty safe. Patient is monitored during the procedure. Usually they put them on a monitor just to make sure it isn't causing any EKGs or arrhythmias due to the shock waves at a rate of 60 to 120 per minute over a 30 to 45 minute time frame. After the lithotripsy is done, after the breakup of the stones, we strain the urine to determine if they're passing fragments of it. Bruising may occur on the flank side where the treatment was applied, so just monitor that site. At times, a stent may have to be placed, so if the patient has a ureter that's possibly already occluded or they're afraid that it will get occluded, they'll place a stent. So basically it's just an alternative route for the urine to go. Sometimes a stent will come to the outside of the body, so it will be placed in the kidney, and then it will come out to the outside of the body and drain to the outside of the body so that we can remove those stones without causing damage to the patient's natural ureter. A ureter scope can also be used to go in and try to grasp some of those stones and take it out. It's basically a scope that's passed through the urethra, the bladder, into the ureter to try to take the stone out. You can also do a nephrolithotomy, which means that they can surgically go in and remove the stone through the skin. Of course, care for those would be getting a consent, explaining the procedure, monitoring the patient for pain afterwards, and then the other huge thing after a treatment like that is to monitor for urine output to make sure that they have been able to sustain their urine output. If so, an obstruction would be a complication of that procedure. So measures to prevent urinary obstruction is high fluid intake. That's up to 3 liters a day. Accurately measuring the eyes and nose. So it's a high priority for the nurse in these patients to monitor for your eyes and nose to make sure they're putting out adequate amount of urine. More questions to assess your learning and make sure you're understanding the content. I encourage you to try to answer them and check your answers in the comment section. We're going to wrap this presentation up for Module 4 by talking about bladder and kidney cancer. These cancers are usually urothelial cancers, which means that they are malignant tumors of the urothelium, which is the lining of the transitional cells in the kidney, renal, pelvis, ureters, urinary bladder, and the urethra. These cancers most commonly occur in the bladder. Most bladder cancers are transitional cell carcinomas and are treated with surgical excision and chemo. Chemo can be instilled into the bladder and may require additional patient teaching. And typically that's about their output. They have to use safe use of toilets for their family so that they are not exposed to the chemo. Cancer could spread if not identified and treated early. And these would be those patients that are having recurrent bladder infections. And also just discussing the history with them. Family history, medical history, medication history to determine someone who might possibly be presenting with a bladder cancer. It's thought that people who are exposed to toxins, chemical dyes, are more at risk for bladder cancer. One of the number one causes that's thought to be one of the major links to bladder cancer is tobacco use. Strange but true. There seems to be a large connection between people who use tobacco and have bladder cancer. This is related to the compounds from the tobacco, such as the nicotine, that affects other organs, and it's found that it does affect the bladder a lot. Anybody who smokes should be encouraged to quit smoking, especially if they are diagnosed with bladder cancer. Radiation may be a treatment identified for a patient with advanced disease, advanced bladder cancer, that cannot be eradicated by surgery. Palliative radiation may be something to relieve pain, and that just means that they're trying to reduce the size of the tumor, and so that it can make the patient more comfortable. Parts of the bladder may be removed. A partial cystectomy may be done as a treatment for bladder cancer. Sometimes they have to remove the entire bladder, and that's when they would have to put in some urinary diversions in the treatment of the bladder cancer. So that would be the development of a stoma, which is called a conduit, where they might take a piece of the intestine and connect the ureters to the piece of the intestine that is then taken out through to the outside surface as a stoma, and then the patient will use a collection bag on that stoma for the collection of their urine. And I believe that's what the next slide is pictures of, so we'll talk about that. These are just some more, some names of the procedures. These all right here are names of those potential procedures that could be done in the event that someone's bladder has to be removed. Here are the pictures of those. This is a uterostomy, the conduits, and then the sigmoidostomies, where they, at times, they can develop a pouch here that they can connect the ureters to, and that's how the patient will be able to take the urine out of the body. Lots of different things, and it depends on the patient and how much the bladder cancer has spread, and how serious the disease is and how advanced it is. So the big thing here, as you can, this one not so much, but anything that's going to have a stoma and they're going to have to do a collection bag is going to require that they have teaching regarding care of that stoma and of the collection device. Wound and ostomy nurses would be consulted to help teach the patient on how to take care of these. So it's important that you help them with body image, and it's important that the patient, prior to leaving the hospital, participates in the care of these. And we want to see them participate in the care of these, so we're going to know that they can and will do it prior to leaving, so that if they go home and they're not comfortable with it, they could possibly have complications from the surgery. So it's important teaching here, and any of these surgeries would certainly be important. The rest of the slides in this presentation is a small case study for you to work on. Again, the answers are in the comment section, so I encourage you to try to answer the questions and then check yourself in order to determine your understanding and learning regarding Module 4. And that concludes this presentation for Module 4, Nursing 150. I look forward to discussing this content more with you in class.